Can I start? Okay. No worries, no worries. Okay. Okay. All right, board. If everybody's ready, we do have a quorum present, and I'm going to go ahead and start the meeting officially. Good afternoon. Today is June the 10th, 2026, and it is 3:38. As a quorum of the committee is in attendance, I would like to call the meeting to order of the Central Health Strategic Planning Committee. As a reminder, a committee member may also be participating by video conference, and we do have two members. We've got Manager Jefferson as well as Manager Kitchens online. So the staff will be managing video and auto feed for all participants closely to make sure we have a legally compliant meeting at all times. Members, I just have two announcements prior to starting the meeting, and one is before we begin the meeting, I have information that the Mars Performance Review update was sent out in the email with the meeting packets on June the 3rd, and I also want to give you all a reminder that we have added the board meeting guidelines. They look like this, cards, to everyone's desk. As you know, these came forward from the retreat that we had earlier this year in April or May, whenever that was. And I would just ask the board members to please take a look at them and let's be mindful of our meeting guidelines. With that being said, I will now take public comment. Do we have anyone signed up for public comment? We're making it accessible to community members. We will now hold public comment for both the Strategic Planning Committee and Executive Committee meeting. Are there any people signed up? None. We have none. We will proceed then. Thank you for your comments, as we don't have any, but thanks for everybody who may be online watching beyond our members. So the first item on our committee agenda is the review and approval of the minutes of the May 13th, 2026 Strategic Planning meeting. Do we have any motions to approve the minutes?
I move that the committee approve the minutes for the May 13th Strategic Planning Committee.
It's been moved by Manager Valadez. Do we have a second?
Second.
It's been seconded by Manager Martin. Those in favor, please signify by saying aye. Aye. Any abstentions? Any noes? Thank you, managers. The next item that we have will be the following. I announce that the committee is convening in closed session to discuss Agenda 2 under the Texas Government Code, Section 5551, 071. It's the consultation with attorney. And at the beginning of okay, so we're going to move into closed session now. And I don't have to announce the time until I get into the closed session?
Well, you have to read the item first.
Oh, okay, sorry. Okay. All right. So the item that we will be going into closed session will be to receive and discuss and take appropriate action on updates related to the Central Health Foundation bylaws and administrative services agreement. Now we can, it is now 3:41 and we will be going into closed session.
Recording in progress.
Now can we proceed? And we've got everybody back on video. Okay, very good. Okay, we're back in open session, and I'd like to announce the date and the time. The time is 4:34, and we are meeting on June the 10th, and we'll continue with our strategic planning committee meeting. And with that being said, I believe that we're ready to entertain a motion based on our discussion and enlightenment from the closed session. I would so entertain one.
I'd like to make the motion. I move to recommend approval of the proposed foundation formation documents, authorize staff and council to proceed with legal formation activities in anticipation of approval by the Board of Managers at its next meeting, and continue working with the board on the operational, governance, and administrative structure of the foundation, including policies addressing the Board of Managers' oversight of the CEO of Central Health role in respect to the foundation and foundation leadership.
A second.
It's been moved in second. Do we have any further discussion? Any further discussion? One more time. Any further discussion? With that, I'll go ahead and take a vote. All those in favor of the motion, please say aye. Aye. Any opposed? And please record, well, they can't vote, but record Ann's and of course to Doris. So Dora, you're a yes or a no? Yes, okay, very good. The motion passes unanimously, and we can now move on to the next item, which will be number 3. Everybody ready for number 3?
Thank you, everybody. Appreciate
Thank
y'all.
you.
Thank y'all.
We will be working with you closely. Thank you for your work. Okay, so team, are y'all ready? We're gonna receive and discuss an update on Central Health Surgical Services. Okay, we've got, Dr. Ali and Dr. Kati, and I don't know how to pronounce that, Marus-dus? Say that again? Madrus, okay. Matarudis, like the Mavs, the team, Mavs, go Mavs, okay. No, they're from Dallas, the Mavs are from, oh, is that right? And the Spurs are playing now, so I'm curious, well, at 7:30 they start. No, but we can get the score. I'm counting on David to give me the score for the Spurs game, because you like that, I know you will, I'll be ready. Okay, is everybody in place, everybody here? All right, we're gonna go ahead and proceed, folks. I'll turn it over, the presentation to you all. Thank you for being here.
All right, thank you. Good afternoon, Board of Managers, Chair Rodriguez, Vice Chair May. I'd like to introduce our Associate Director of Surgical Specialties, Dr. Jawad Ali, and our General Surgeon Extraordinaire, Katie Mavrudis. Jawad has been with us now for about 2 years. Within his scope is general GI, hepatology, podiatry, ENT, and general surgery. You all may remember that I think we presented a few months ago, but since I've been here for the past 10 years, we've had a wait list on a GI wait list of up to 1,800 on that wait list. Thanks to the work that Jawad has done with the department, we're now down to less than 100 on that wait list. And by the end of the fall, he's I'm not going to say fully staffed up because we're going to continue to staff up, but the amazing staff that he has recruited, we should have access by the early fall of less than 2 weeks for access to general GI, and for endoscopy less than 2 weeks, and that is due to a lot of the work that he has done. So huge kudos to him. Katie, I think, just celebrated her first year anniversary, really helping build our surgical program. And what I have to say is that if there is one person that gets overutilization of their template, of their schedule, it's Dr. Mavrudis. I think it was 107% of utilization the last time I looked at it. So we've got 2 underachievers today that are going to present to you. And with that, I'm going to step away and turn it over to them. Make sure you hit that right there.
Thanks so much, Dr. Salsa, and excited to present to you all today. So I'm Jawad Ali, as Alan mentioned. I'm the Associate Director of Surgical Services. And I did my general surgery residency here at UT Austin. I was a part of the first class to graduate under the new Dell Medical School, and the last class to graduate from Brackenridge Hospital. Rest in peace. I then went to UC Davis for my bariatrics and advanced endoscopy fellowship, and practiced at Kaiser Permanente in Northern California for a few years before being asked to join some of my old attendings at Cedar Hayes to help build the trauma program, as well as an elective surgery and rural surgery practice. I was there for 5 years before joining Central Health 2 years ago, and I'm grateful to be here. It's really been an incredible journey.
I'm Katie Mavridis. I joined Central Health in April of 2025. So I did my medical school at Emory University in Atlanta, and then I went up to the University of Pennsylvania where I did my residency in general surgery. While I was there, I did research into how the structure of health systems impacts the quality of care delivery, very pertinent to what we do here, of course. And I got my MBA in healthcare management at Wharton. I was then in practice in rural New Jersey for about a year and a half before a job opportunity for my spouse brought us down here, and I was delighted to find such a natural fit at Central Health. It's truly been a pleasure to work in an organization that practices what it preaches, and I'm really proud of what we've been able to build. Next slide, please.
There should be another slide. So the general surgery service line started 15 months ago, and we're excited to present what we've been able to accomplish. Our goal as a service is not only to increase surgical access, but to provide high quality, cost-effective care that touches the entire patient journey across our colleagues with primary care, outpatient specialty care, and inpatient settings. So today we're going to go over the structure of the service. We'll also present data around access and surgical volumes, as well as touch on some of the quality improvement projects we've done, and close with our future-facing goals and take any questions. So this is a small but mighty team. It consists of 1.8 physician FTE, a clinic nurse, and a dedicated team of MAs. We're also excited to add a surgical APP in September. I'll also give a shout out to the broader Central Health infrastructure that we're really grateful for. It really supports the care we deliver. And this includes our operations partners, the navigation team, transitions of care, as well as our IT and EHR teams. So our clinic is just down the street at 211 Comal at the East Austin Community Health Clinic. And I've worked at many clinics across the years, and this is a really high functioning, capable team that enjoys working together and enjoys getting things done. We do our outpatient cases at the UT Surgery Center in Bailey Square, and our inpatient cases at Dell Seton Medical Center, as well as Seton, Maine. So I'll turn it over to Dr. Mavridis to talk more about the service and some of the projects she's led.
Thank you. So at Central Health, our general surgery service line really focuses on what we consider the bread and butter of general surgery. If we can go to the next slide. What that means is that we do primarily scheduled elective outpatient general surgery. We see patients for gallbladder diseases, a lot of hernias, and a lot of lumps and bumps or small soft tissue masses. We collaborate with our subspecialty providers at the University of Texas through a pretty close network that we've built so that we can ensure that any patient that's not appropriate for our scope gets timely and efficient access to care as well. Since the service line launched, we've seen 833 patients and done a little over 700 cases. The majority of our operations are done at the University of Texas Ambulatory Surgery Center, but as Dr. Ali mentioned, we're also doing inpatient cases at Dell Seton. Typically, those are patients that are more medically complex and not appropriate for an outpatient setting, potentially requiring admission. And then we also work with the teams at Seton, Maine, largely because they have access to many more Da Vinci robots, which allows us to do more complex, minimally invasive surgeries. We also try to be flexible and accommodate what the population needs. So I personally review every incoming referral. We get about, now at this point, about 35 plus a week. And if it's something that I can't offer, I try to find the right provider for that patient and specifically direct them. Sometimes I'll text the provider and make sure they're actually going to get in. Or we just offer it. So I found that patients with feeding tubes, for example, were kind of getting bumped around. Their tube would break. They would go to the ER to get it replaced. We stock them in the clinic, and it takes me 5 minutes to replace them. So that was an easy fix that I didn't know we needed to offer, but has been a very, very low effort, low investment thing that we've done that hopefully keeps our most complex, chronically ill patients out of the emergency room and in their homes with their families. Next slide, please. In that line, the service line has been shaped by the population that it serves. I'm excited to share with you some of the projects that we've tackled in this past year to build a service line that is designed for our patient population, not one where we're trying to fit them into a mainstream, more typical commercial plan. So starting off, if you've ever had a procedure and been handed a pink body wash the night before surgery or HIPAA cleanse, that is ERAS. That is a component of the enhanced recovery after surgery protocol. There are three main pillars to our ERAS protocol. We really focus on perioperative nursing education with a lot of contact points for our patients. We have a phenomenal RN who speaks Spanish, which is a blessing for our patients as well. And she calls every patient 7 days before surgery to make sure any unanswered questions are answered. They have their procedure, and then they, after surgery, get a call from our medical assistants to screen them, make sure they got their prescriptions, make sure there's any identifiable, modifiable things we can do. And often if there's minor things, we can see them in the office and again, prevent that unnecessary emergency room visit. We also work on narcotic reduction, so we do multimodal pain control, both in the preoperative setting and then after surgery. We're really focused on reducing our use of narcotics for pain control. My ERAS patients really rave about their access to our team. They're always saying, I talk to so many people, everyone's always calling me, telling me to call. It's what I wish my parents had access to, what I wish my loved ones had access to. That's how we designed this, with sort of concierge medicine for the patients that wouldn't be able to afford it otherwise. Next slide. In that vein, we've been able to collaborate with our phenomenal transitions of care service line here at Central Health to do safe surgery for unhoused patients. What that means is that we provide equitable care. And for surgical patients, that often requires wraparound support to ensure that they have the same access and the same opportunities to things like ERAS, to things like getting their prescriptions filled and picked up for them if they don't have a family member in town that's able to help. So for our sheltered unhoused patients who have a stable bed, what that usually means is that we have them go to a skilled nursing facility bed, one of our Central Health beds, just overnight for postoperative anesthesia monitoring because it would not be safe to discharge them back to a shelter. And then as long as they're comfortable with that, then they'll be discharged from there by our Central Health skilled nursing facility team. The thing I'm most proud of, though, is that for our unsheltered unhoused patients, the people who say they live in the woods, live on the streets, live under the bridge, live under 35, we work with our respite team. And I think you all have heard from Dr. Kwong recently. She's truly a miracle worker. And so we'll admit our patients to respite before surgery to make sure that they have good nutrition. They can shower the night before surgery. They can maintain sobriety prior to surgery to make them safe for anesthesia, and that they get there on time so that they can actually have an elective outpatient procedure the same way anybody else would. They then can go back to respite and continue to get the amazing medical and supportive social services that respite offers. And so I've had a patient, one of my first unhoused patients, was a heavy substance user and needed to stop using to be safe for anesthesia. He had a pretty big surgery that was going to be fairly complex to repair. We were able to connect him to the addiction medicine team that's part of CUC and Central Health, as well as our case management services. He got a loaner phone, and I followed him out to about 3 months. He was still maintaining sobriety and was so proud that he had done it, and so grateful for the kind of 360-degree care we were able to offer. Next slide, please. This is in progress, but something I'm really excited about. I designed a data tracking tool built into our electronic medical record, Epic, so that we can a priori track our preoperative risk factors, our postoperative outcomes, and intraoperative decision points, and then have that real-time feed into a live clinical dashboard for surgeons to monitor their individual outcomes, and so we can monitor for specialty specific. Right now there's 2 of us, but the dream is that we're much more. And so this would allow us to critically assess our outcomes and make sure that we really are providing the highest quality care, sort of objectively holding ourselves to the highest possible standard. So this is designed and modeled after the American College of Surgeons National Surgical Quality Improvement Program, which is a program that hospitals actually can participate in. Practices are not eligible, but it's something where you really just have to demonstrate through data that you're achieving high quality standards. And so it provides, we're building the infrastructure into our electronic medical record now so that we can hopefully use it as our practice grows. Next slide, please. Go ahead.
Thank you. So our next phase is continued growth. Like most things at Central Health, we need to grow to address the increasing referral volume. So this starts with an additional surgery APP, and then eventually another full-time general surgeon. We're also working to increase integration across inpatient settings, as well as across the surgical community in Travis County. This allows us to intervene earlier for patients, decreasing ED utilization, as well as decreasing hospital length of stays and more involved with the hospital teams. One specific goal we have is to increase operative volume by 15% by April of next year. Next slide. We can go to the next slide. Thank you so much, and we'll take any questions.
Thank you. Okay, members, we'll just go around the table. I'll start with Cynthia Valadez for her questions and comments, and we'll go around one time, only one round, because we've got, we want to stay on schedule, and they've got me on a tight schedule with these presentations.
With respect to the way you set up this particular department, our clinic, and dealing with the more complex, medically fragile, chronically ill, et cetera, how many, to be a fully built-out clinic or service provider, how many people do you think you're going to need? I'm talking about physicians. In light of the growth that you're seeing happen within Travis County, and understanding that at some point in time, it may be expanded to beyond the boundaries of Travis County.
I think, there's two parts of this. One part is bread and butter general surgery, as Dr. Mervis mentioned.
Right.
And I think initially we'll at least need the APP and the full-time general surgeon, probably another general surgeon. I think the part of it that is more complex is when it gets to the surgical subspecialties, even along the general surgery pathway. So like foregut surgery, bariatric, surgical oncology, these other specialties. And for those, it probably makes sense, at least at the outset, to partner, but then eventually have our own specialty surgeons. But open to your thoughts, Dr. Mervis, as well.
I agree. I think at our current kind of growth, our referrals look like this, because we've really engaged with the CUC community, and I think we're uncovering volume that was previously not referred because people didn't think they would get seen. So I think we could use 2 FTEs of surgeons easily at this point, in addition to the PA who's starting this summer to help us increase our conversion rate of clinic visits to operative cases.
I appreciate that, and I think that previously, they weren't being seen because we didn't have the ability to provide the service, so thank you very much for being here.
Thank you. Chair?
Thank you for the report. One question I have is, I know you're doing your quality dashboard. I'm wondering if you could share with the board some of the data points or measures that
Sure.
how do you measure quality, or what do you measure in quality?
Absolutely. So we're looking at things like 30-day readmissions, urinary tract infections, delayed return of GI function, a lot of things that prolong hospitalization, unexpected admission. So the outcomes that I'm tracking, the specific complications, come from NSQIP, come from the American College of Surgeons, and are applicable across pretty much any surgical specialty. So that's what we're starting with. What's nice about this tool is if there was a specific observation we had that this is some certain outcome is happening with all of our patients, we could very easily add that and then track it and do a plan, do, study, act cycle to intervene in sort of a typical QI framework.
Just a real quick follow-up question. What can the board do to support a culture of safety and quality for patients?
I'm sorry, I didn't hear the first part. I apologize.
What can the board do to support a culture of patient safety and quality?
I think it's holding our network partners and our direct employed surgeons to the same quality standards. So we need to say what is an acceptable surgical site infection rate, for example, and then hold everybody to that standard. So being really targeted, I think, would be key, and then holding our network partners accountable.
That's an excellent question. Thank you so much for that. I have a question for you. How long has this program been in existence, and how many people, you may not have the exact answer, but I have a general idea how many people have been served?
So we first started in April of last year, and then it really took off when Dr. Mervis joined in June.
I joined in April.
In April
7th, yeah.
April of last year, and so about 15 months.
And we've served, I think it's 833 patients, I
That
believe.
is phenomenal. Thank you for that.
Well, thank you for that presentation. I have a couple questions. I'm glad that you're collecting quality metric data and it's aligned with national standards. Is that something that will be provided to us, that we'll have access to see where we're at? And so I understand that you're collecting baseline data and we can see the improvements over time, so that would be helpful. Second, given the population that you're serving, and I know this is something the organization still has not adopted a policy around AI, but I've been involved in multiple studies, including utilizing AI optical tools for endoscopy, and that can minimize biopsies, especially for our patient population, and ability to see and treat right at the moment. Is that something internally you've discussed? Are there plans? And so it would be interesting to know what kind of clinical tools you're thinking of as we're moving forward.
Sure. Yeah, no, it's a great question. I mean, I think, you can't avoid, but be inundated with AI, news and new things that are coming up. So we've taken a very methodical approach to adopting AI. I'm part of the AI work group. We also have AI Governance Council, and we're working on a policy for the responsible use of AI to address issues like equity, accountability, oversight as you adopt these AI tools. I mean, I'm a huge believer that we need to use AI. We need to do it responsibly, and that physicians need to be involved in how we adopt these tools. Specifically to surgery, the first kind of use case that we're looking at is tools to decrease ED utilization by predicting which patients are at higher risk, for example, intervening earlier for those patients. But to your point, there's a lot of, really every facet of care can be touched by AI in some way. We're currently in the process of building a framework to adopt AI responsibly.
Oh, great. And that could be also possibly a question to Dr. Lee in terms of, you mentioned there's so perhaps updating us on what Central Health is doing in relation to that and who's involved. And so maybe something that we can discuss, and we need to discuss and assess actually more of a governance policy. So you don't have to answer, but it's something that we should be thinking, because before we clinically implement, we also need to think about organizational readiness and setting up the foundations. Lastly, what is the number one surgery that you conduct, operate on amongst our population? I'm just wondering, is there something more prominent than others within our population?
Yeah, so in my practice, and probably I'll answer after this, so it would be gallbladder surgery, hernia surgery, and then I do a lot of endoscopy as well.
Yeah, for me, it's gallbladders, hernias, and a lot of lipomas that are causing fairly significant symptoms, and a lot of ER visits related to that, actually. Benign soft tissue masses, but people are not sure where to go, and they get scared that they have a growth, so they go to the ER. And then to backtrack and answer your first question, the dashboard, once it's live, I think would be very appropriate to share with this audience. Many other surgical specialties have public reporting of their outcomes. Thoracic surgery is known for it with the Society of Thoracic Surgeons publicly reported database, so you can look up who's the best surgeon for aortic valve surgery. That does not currently exist for general surgery in the same way, but I think certainly within this framework we would be, I think we should be held accountable and certainly should share that with you.
Thank you. Kind of doctor to doctor, silly question, but to handle ER bounce backs, who handles call post-op?
We do.
Do you carry the beeper?
We have an after-hours triage nurse system that's pretty fantastic, and when I've had 2 patients get readmitted, and I've for both of them just admitted them under myself and managed it. I do work with the UT residents, and they've been a great sort of on-the-ground resource. So we back each other up.
Okay.
But yeah.
So, thank you. The other thing is, subspecialty surgical care is a conundrum. What is y'all's plan for that moving forward?
I mean, there's a short-term plan and a long-term plan. The short-term plan obviously is to integrate with the specialty groups that we contract with, and then also, I think, increase accountability and closing the loop as our patients go to those practices. And the long-term plan is to, when it makes sense, to bring those physicians in-house.
Do you see UT starting fellowships in vascular, thoracic, colorectal, stuff like that, and integrating that with us, or?
How do you mean?
Well, I mean, do you see them starting fellowships in those things here at the medical school?
I believe they already have a vascular fellowship.
You do?
I'm sure, I think it's inevitable, down the road that UT is going to be kind of a full-fledged medical center with every fellowship. I think it's a natural partner to have the county health system. We partnered with the Academic Medical Center, and so we're working on kind of our protocols to integrate learners in our environments.
Thanks.
I don't have any questions. I just want to thank you. This is very exciting, and we'll be very interested to hear how it all.
Thank you.
And then perhaps we have questions from either Sedora online or Ann, our managers that are online. No questions? Thank you, none? Thank you. Thank you very much for the
Good
presentation.
report, that's all I have to say, good report.
You took the words out of my mouth, Sonora. I was just gonna say, this was a very informative report. I really appreciate it. I think this board appreciates the work that you're doing. And I could only tell you to keep it up and feel free to come back and give us more good news. Thank you.
Thank you.
Well, we appreciate the support. I think this is an incredible organization. I think it's really something special. So thank you for that.
Thank you for sharing that. Okay. All right, our next item is number 4, and we're gonna receive and discuss an update on the Mental Health Crisis Center and Continuum of Care in Travis County. We have Sydney Harris who will be presenting. And Ms. Harris, it is 5:00. And we're just behind 6 minutes from our timeline, so you're doing good. We're doing
right.
good.
And Vice Chair, if I may, I was going to just offer a brief bottle in front
You
on
wanna
this topic.
set this up?
Tee this up.
Absolutely.
Okay, so good evening, managers. Tonight, we're going to provide an update on our work with Integral Care, Travis County, the City of Austin, and other partners to better integrate behavioral health services into the broader continuum of care, particularly as it relates to the development of a mental health crisis care center, equivalent to the diversion center conversation we've been having in our community. I know this is something many of you have been advocating for and care deeply about, and rightly so. This work is deeply important to us because mental health needs do not exist in isolation. People experiencing mental health crises often also need medical care, housing support, substance use treatment, and help navigating other benefits and services. Today, these services are still fragmented across different systems, leaving families, first responders, hospitals, and patients without a clear place to turn for people with complex care needs. A more integrated approach would give us an opportunity to close those gaps and build a crisis response system that is more humane, more effective, easier for people to access when they need help most, and has a chance to help steer folks safely toward the more outpatient, lower acuity side of care if we catch them at that time of crisis. Sydney Harris, our wonderful senior consultant for health system design, brings many years of experience in this space, has been instrumental in shaping much of the structure and thinking we have today in our region, and is also shaping a proposal now for what a mental health crisis center could look like as part of a more fully integrated system of care. She and I and others have been actively engaging with Judge Brown, Commissioner Howard, Mayor Watson, Sheriff Hernandez, and many other key leaders through the Executive Leadership Collaborative convened by City Manager T.C. Broadnax and others to build alignment around the vision, structure, and role of a crisis center like this. This collective group has met multiple times, is going to reconvene again later this month, and there is, I believe, emerging broad alignment around this direction, which is very exciting. Sydney will walk us through our proposal today, and in parallel, our consultants at Huron are developing a high-level estimate of the capital and operating costs required to launch and sustain a center like this, including a 5-year financial outlook. We expect to have an initial estimate by the end of June, followed by a more detailed view by mid to late July. And once we have a clear picture of the financials, we'll of course bring the information back to all of you. A final thank you also to our Integral Care leadership and board. It's been a collective effort. And so with that, I'm delighted to turn over to Sydney, and JP walks the details. Over to you.
And Sydney, you're gonna have about 20 minutes max, so just giving you a heads up on the timing. Thank you.
Thank you. Thank you, Chair Rodriguez, Vice Chair May, and Board for your time this evening. I appreciate it. We are going to go through the mental health continuum gaps that we've been looking at with our partners at Integral Care and at Central Health. Many people experience a mental health illness, so it's 1 in 5 for adults, 1 in 7 for youth, and 1 in 20 will experience a serious mental illness within the year, have before, or have in the future, or well in the future. Suicide was the 8th leading cause of death between 2018 and 2020. 1 in 5 Texas teens considered suicide by the end of 2022. It doesn't only affect the individual, it affects the workforce and our economy, our neighbors, and our friends. Specifically for Central Health, the vulnerable population that we're serving is roughly 217,000, and of that population, roughly 43,000 have a behavioral health diagnosis. Next slide, please. I want to walk through really quickly what the crisis continuum care looks like. This was developed by Dell Medical School during the Austin State Hospital redesign. This is known as the crisis care continuum. Many people actually enter into mental health system of care at the exclamation point where the crisis is. That's when, unfortunately, a person experiences it for the first time. And so they are then either picked up by an officer of the law and taken to an emergency department or, unfortunately, jail, or an individual at times doesn't even have anywhere to go to receive their care. And it's about 60% of individuals that are coming into the mental health system at that exclamation point. Next slide, please. Some of the evidence that we've been looking at across the United States to support the crisis services is an example out of California. It is called the John George Psychiatric Hospital, and what they've created is a specific mental health crisis center or an emergency department only for mental health care services. This allows not only individuals to receive the care at the right time in the right place, but it also allows other individuals that are coming into emergency departments for a heart attack, a stroke, a rash, any other ailments you might go to for the ER, the ED, they actually get seen more quickly and more timely because not just in Texas, but across the country, people will wait in emergency beds for up to 608 minutes when they are in a mental health crisis. So that individual is needing time to stabilize, while unfortunately other individuals coming in for general medical needs in their emergency department can't get to that bed. So what you see is John George created this model and allowed individuals to get mental health care more efficiently, along with general health more efficiently as well. And on the right-hand side, you can see that this is a cost saving. So when people get to the right bed at the right time, it saves about $3,500 per psychiatric individual that comes in for care. Next slide. Some other evidence that we've been looking is actually right here in our backyard through Integral Care. They have the Inn, which is a crisis residential, very similar to our therapeutic diversion program that's currently operating. You can see that by being served in a crisis residential, this is what you can look at like a step down. So you may have knee surgery, and then you need to have physical therapy afterwards. Well, our brains need the same kind of care. You can come in with a mental health crisis to an emergency room or into an inpatient, and rather than being discharged right back to your home, sometimes you need a little bit longer to receive the care and recovery back into the community. And so that's what a crisis residential facility does for individuals experiencing mental health illness. And here we do have the Inn with our partners at Integral Care here in Travis County. You can see the savings that they've been able to calculate by using the Inn instead of other inpatient facilities, or of course other than jail, when unfortunately that is the alternative. There are other examples of crisis respite, which we've looked at in New York, who also provide the same benefits for the step-down individuals from coming out of the inpatient facilities. Next, yes, thank you. Continuing with our successes, these are the current services in Travis County that are operating. We have the Sobering Center, the Therapeutic Diversion Program, the Expanded Psychiatric Emergency Services, and the Inn, which I just mentioned. They are all serving our population experiencing mental illness, and they are all proving to be successful. However, our population in Travis County continues to grow. A lot of people love to live here in Travis County and Austin. You can't deny them that. However, our services have not scaled for the mental health needs of our individuals that are coming. And so we are doing a wonderful job. We just need to grow that wonderful job to care for all of our individuals in Travis County. a lot of individuals you might hear talk about the bed count. That's been a lot of conversation, especially here in Travis County, throughout the Austin State Hospital redesign, and even into today's counts. There's not a great amount of information on bed counts per population for other services. However, there are for the inpatient. So these are our current numbers today for 2026. You can see we have seven psychiatric ED beds, emergency department beds. Best need is 25, so we're missing about 18. For our observation, we have 17, and for our population, it would need about 16. And you go over to the inpatient. Those 310 beds include exclude hospitals such as the Austin State Hospital. Just a reminder, though, that the Austin State Hospital is a region hospital, and so it's not just for Austin. It is also for 36 other counties in Central Texas. You also have your Cross Creek, your Austin Oaks, and there are some beds in Georgetown, but they are not included in here because it is outside of the Travis County border. And then our sobering and detox, 268 does look like a lot, but you can see it's not meeting the needs. The national average is about 34 beds per 100 population. And those 268 beds, they are actually for a lot of individuals who have the means to pay out of pocket for services or have a payer source. So unfortunately, it does not meet the needs of our population that we serve here at Central Health. Next slide, please. And this might look a little bit similar, but if nothing is done or only a few is done, as you can see, the inpatient does increase. There are some slated beds available to increase in St. David's North Campus, along with Cross Creek has the ability to expand their beds as well, but still their expansions will not meet the need based on our population growth in 2040. So what we are looking at, and ultimately a recommendation, is a crisis facility service model that includes all of these services here on the right-hand side. It would look like a psychiatric emergency crisis stabilization to allow individuals to be triaged and stabilized when they're in a mental health crisis. You would have an opportunity to have observation up to 72 hours. Sometimes a person only needs 72 hours. And we would also like to see inpatient psychiatric beds. So an individual can walk in, maybe they didn't stabilize after the first 72 hours and they need a longer term stay. And then, of course, we want to make sure there's integrated care. Everybody needs primary care along with mental health care. It's the whole person that we want to care for. So we have primary care, dental, laboratory, and pharmacy as well. And then sobering and detox. Many individuals that are living with a mental health illness also have a sobering, a substance use, diagnosis. And then, of course, individuals are entangled in the legal services. So we want to make sure that we're able to help them with their legal needs as well. It'd be a one-stop place. Law enforcement drops off. People can walk in themselves. Family members can help drop off their loved ones, and EMS can drop off. And it provides stabilization and care coordination for those experiencing a mental health illness. And then what we've seen from our partners or our consultants at Blue Cottage, they're also seeing the same need in our county. What we've called it is a balancing act. So if we don't have crisis in the middle of outpatient and inpatient, ultimately one is going to be needed more than the other, or they're both going to be needed in having a lot of bottlenecks on both sides. So Travis County is in need of a crisis stabilization facility for individuals experiencing a mental health crisis in the moment. I believe that's it. Thank you. Open it for questions. Sorry, Anne.
And so with all of this, do you guys have a plan? Like what you're working towards and how you're gonna do that?
Yes, we are working to finalize that plan, and as Pat mentioned earlier, we are working with Huron, a consultant, to help us analyze the financial aspects of capital and operations in a pro forma for up to 5 to 10 years. That way we can come back with more insights as to what it would take to build such a building and provide the services needed operationally.
Thank you. Following up on Dr. Brinson's question, so you mentioned the performa in the capital. Would this be 100% funded from Central Health, the capital? Given that there are multiple players, so just has there been a conversation around that?
Would you like me to take that one, Sandy?
If it's more appropriate, yes, please.
Sure, I'm happy to. I'm happy to.
Sorry.
So, Dr. Misetti, we have been in regular conversation with our colleagues at the county. I know Nirav is here, so I don't want to speak out of turn for them, but there have been multiple conversations about how Central Health will not be the only entity helping to fund, could not be the only entity funding this need.
Well, yes, I concur with that, giving all our services and future plans and services is just also ensuring that we continue there's sustainability of the services. So that's always something that worries me, that this is a great vision. It's just thinking about something that we can carry on forever, that it's not temporary, giving a lot of financial challenges that we may have in the near future, per se. So that is just always a concern. I'm glad that you're having these collaborations. My final question related to the services that you offer. Is there any social services involved in this? Because I don't see it, or is it embedded into one of these categories?
Yes, there would be social service as well.
Okay, because I don't see it here.
Where would it be?
Meaning like within the building or
Within the programs, the individual programs that you have?
within the team. I mean, I would imagine that they would be throughout within each level. So at inpatient, you would have peer support services. You'd also have peer support services in the outpatient services as well.
So
And social workers
it
and
might
counselors.
be beneficial to have more of a centralized social service for a patient that are not, we want to ensure that they're connected, because they may fall in the cracks if there's not a dedicated service line. So that could be perhaps part of the innovation, the uniqueness that we could bring to the table. Because when I see here, sobering and detox, legal service is wonderful, but there's something missing, and that what I see is the social service component within this model. With that, well, thank you for all your efforts and for this presentation, and thank you, JP, as always.
And I'm gonna do a follow-up on that social services question. Sounds like it hasn't all been baked yet, and that's fine, understandably so. But I'm gonna ask you to come back, either you or through Monica's team or Dr. Lee, come back and give us more information on what that is beginning to take a shape and how it's gonna be used throughout the process in all of these integrated services. Thank you. Yes.
So, well, first of all, thank you so much for all of your work. I know this has taken years and a lot of collaboration and teamwork and a lot of stopping and going and yeses and nos all around. And I really appreciate the education around the continuum of care and the service model and now the pro forma, so you're going to the next step. I think my question is really around the sustainability or the sources of funding, which I think no one entity can take on alone, and braided funding is always kind of an approach to take. And then actually going back to the social services, the question I have is like, have you considered, or is case management part of your service model? Because I see case management as one of those things across whatever program is going on, ends up being an effective way of connecting the dots for patients, most importantly.
Yes, I guess I will go in more detail next time, and I apologize for that. But yes, I will have that in the next round.
Yeah.
If I may, to that point, if you intend to do contracted social services or case management, I would like to know that. Thank you.
So a big gap that I see here is that the adults with the mental health issues that are struggle, the people that are struggling with it in the adult world start out with those in the adolescent, baby world, going to juvenile, young minors, and then into adults. They have not been addressed. The school system is ill prepared to handle what teachers are dealing with in the classroom. That's why they're leaving by the thousands. I myself have held children with the breakdowns who have, you can clearly tell they have anger issues, they have mental health issues, and the old MHMR, the current IC, Integral Care, are not addressing it. The schools are not addressing it. There's no one in the school to address it because the teachers are not diagnosing what they're seeing their kids acting out. They just want to get their paycheck and get the heck out of there. So my concern is that, is Integral Care going to look at, you talk about holistic, well, holistic starts from the birth to the grave. And the two ends are where we are facing, I think, the greatest gaps in dealing with our population, especially our population of poverty and of color. And so I would recommend that you all look at a good analysis of the data that is already being collected by schools, and try and figure out how we as an agency to help provide support services along with the other agencies and schools and governmental entities to combine our resources and help address those. I'm speaking from this perspective, having spent almost 4.5 years in a hospital room with my daughter. You don't know how many babies were given up by their parents because they were medically fragile, chronically ill, or they had multiple issues that nobody knew what they were dealing with really. And they just let them cry in their rooms alone because there weren't enough people, hands to deal with the children. The babies just stopped crying. Now, when a baby stops crying and grows into a child that stops providing or showing their emotions appropriately and just shuts down, and it is going to come out in another way. And the way it normally comes out is anger, frustration, violence. And a system like Integral Care is it's very hard for them to look at how we're going to deal with our children, our kids that are 18 and under, 0 to 18. And yet that is what we're dealing with for those that survive into adulthood. Because those families have been broken up a long time ago. They're gone. They're split up because they don't have the resources, they don't have the training and the capacity to be able to learn what they're dealing with in their household with those family members that they start out loving to death and then just can't deal with it because they don't have the training and the education and the supports. So
Manager Valadez, do you have a question?
the question is, when is Integral Care going to look at those issues? I've brought this up to Integral Care employees every time they come to make almost every time they come to make a presentation to us. And I don't appear to be seeing any changes occurring in the system because I think
They can't answer that specifically, but we can make them aware of that.
well, your
And
executive
perhaps-
director for Integral Care, if you're working at redesigning the system.
They're not Integral Care.
Oh, I thought you said mental health.
Well, the
The whole,
presenta-
the
yes,
whole
the
world.
whole thing. And this-
Yeah,
our
well, so
role
it's
in it.
all the agencies that
Yes,
are
ma'am.
providing mental
ma'am.
health, that's
So
what
what
I'm
we
referring
can
to.
do, though, since that is a concern, we will raise it
Okay.
when we take care of
I get
that presentation with
Failure
Integral
to
Care.
understand or communicate is
Yeah.
the number one issue.
Okay, thank you very much.
Sorry.
Manager, we still have 2 more people online. It's 5:24 and we're running a little behind, so I would ask Manager Kitchens to put her comments together, and then also Ms. Sedora Jefferson, and see if she has anything to say.
Okay. So my question is, first off, let me say thank you to everyone involved with this. It's great work and very much needed. So I really appreciate getting an update today. My question is the crisis facilities service model that you presented, is that the final recommendation or is it still under development?
I would say that the one I've presented today is not fully baked, as Vice Chair May has alluded, and we are still actively working. This is a quick ask, and we are doing as fast as we can to get the information. This was the first opportunity we could provide an initial view of what we're looking at.
Okay, has it been reviewed and approved by the other entities that are involved, such as Integral Care?
Yes, we are actively working in partnership with them to prepare this information that came today and future information.
Okay, and then I think I wanted to confirm that you said y'all working on Performa and that would be end of June. Did I hear that right?
We will have high estimates by the end of June and final numbers by the end of July.
Okay, then the last question is, in terms of services, have y'all had discussions yet about housing services? And really what I mean there is, you know, what happens after someone gets discharged? Particularly since the unhoused population would probably be a significant portion of people who are served. Have y'all had any discussion about that?
We have, I wouldn't call it necessarily housing, but transitional step-down crisis respite or residential, so that individuals that are leaving a mental health crisis center can continue their care at a lower level of care that's more appropriate for them, and then prepare them for permanent supportive housing or back into their own community or their care with their loved ones.
Is that part of the resources that are being considered? Or is that just the expectation that you'll have to rely on what's already out there?
I can answer that is part of our performa that we are looking at with Huron and how much it would cost so that we can understand exactly what the ask of our partners coming to the table need to present to make something successful and sustainable.
Okay. All right, thank you very much.
Thank you, Manager Kitchen. Sedora, Manager Jefferson, any comments?
Just a remark that I'm glad to see that there is a lot of intention and focus around having a approach to mental health care. And so I look forward to the additional information to come, especially around partners and funding. Thank you.
Excellent. Thank you very much. All right, managers. Oh, yes, there was one more question
Just
from.
one question. Given the numbers that we have, 1 in 5, and you mentioned with adolescents, suicide rates, who's the population?
The population we're planning for is anyone that would need mental health, specifically, of course, our vulnerable population, so children all the way to adults.
Okay.
So we're not excluding anybody based on age.
Perfect. Thank you.
All right, thank you very much. All right, next item will be, we'll start taking item 5, which is receive and discuss an update on the safety net focus regarding the community health needs assessment and the gap analysis process. We've got our staff presenting, Tara and Drew and JP. Looking forward to what add-ons and additions you can share with us. And just know, I know that the other item that we have is not going to be a long item, but we are trying to at least finish up our meeting no later than 6 o'clock. So if we can kind of go from there, that gives you enough time.
Will do. Want to kick us off, JP?
Yes, good evening. Before we provide you with updates on what we've been doing and where we're at with the community health needs assessment, I would like to very briefly review the scope. Oh, sorry, getting ahead of myself. Gotcha. Okay, thank you. So as a reminder, we expanded the scope of this analysis to the 11 county Level 1 trauma catchment area. This allows us to better prepare and predict what types of needs and demands among the safety net population in our neighboring counties we could potentially be supporting. The map on the right shows this expanded analysis area. We will, of course, provide the most detailed analysis on the areas we are charged with serving today. Travis County, which is highlighted in blue on this map, and Community Care's defined service area, which is highlighted in orange. Again, this work will support the development of new and updated strategic plans for both community care and central health, and it will inform the development of a comprehensive facilities plan for our entire system. To ensure close collaboration and validation on deliverables and findings, a work group of community care and central health staff meet with our consultants at least weekly in working meetings, and a broader staff steering committee, including executive leadership from both organizations, meets every other month. I'll now defer to Tara to provide some additional perspective from community care.
I'll keep this brief. I think just the way that this has been organized has been really fortuitous. Usually we conduct this in-house. As a reminder, we must do a community health needs assessment as an FQHC for HRSA, and the way that the timing is happening with this, we should have completion by February, which aligns with the timeline that we need, and it will be one of the inputs in the Community Care Board strategic planning process, in addition to some of the other work that's being developed both by Central Health and as we kind of move forward to make sure we've got good alignment between both organizations.
Next slide, please. Okay, so this is just a brief update. This does mention some deliverables that you would have heard about or hopefully recall from previous presentations that we'll go into in more detail later on in the presentation. So these last 2 months since we've signed the contract have really been an intensive startup period as we set ourselves up for success. So I really want to thank everyone for their commitment. It's been a truly collaborative effort. So starting with our key accomplishments on the left, we piloted the resident survey in English and Spanish with a focus on getting feedback on the structure and questions and making sure that our community members could understand the survey and format. And we had a good feedback from that community conversation in Precinct 4 back in May. And I want to thank Vice Chair May, Manager Valadez. I know you were both there. It was good to see y'all there both as board members and community members as well. We've also been hard at work reaching out to a wide variety of organizations, refining our question guide, and working to schedule more than 30 key informant interviews in the coming weeks with our vendor, Kulik Strategic Advisors, or KSA. In parallel, we've had data subject matter experts working to confirm our secondary data indicators, so quite a lot going on all at one time to get us ready for the next phase. So that brings us to our current focus. We took feedback from the pilot, and after many rounds of refinement, we are launching the resident survey tomorrow, taking good advantage of the Precinct 2 community conversation with Commissioner Shea. We're also continuing our work on key informant interviews. And then next, down at the very bottom row of the current focus, we have our capabilities and gap assessment, which has always been part of the project, but you will have noticed that the timeline for this element has shifted earlier. JP will be speaking to this more later in the presentation. So moving on to our upcoming focus, that's that column on the right. In the coming months, we will have focus groups, which will give us the opportunity to ask questions that are too complex or challenging to answer or to ask in a survey. And then for all deliverables, KSA will provide staff with preliminary findings so we can prepare for our next staff update in August and a KSA update in October. And then I'd be remiss in mentioning there will also be an update to the Community Care Board in July as well. Next slide, please. So I know it looks a little small projected up on the screen, but hopefully you can read okay in your printout. This slide just provides more information on the interviews, resident surveys, and focus groups that I mentioned on the previous slide. So in the center, we are using resident surveys to hear directly from as many residents of the Central Health and Community Care Service areas as possible. The survey findings are then bolstered by those columns on the left and the right. So shifting to the left, the key informant interviews will help us sample a variety of perspectives from those with deep knowledge of the needs of Travis County, the Community Care Service area, and the 11 county trauma catchment area, making sure I'm getting all my areas right. And then moving to the right, the focus groups, as I mentioned, will help us really dig into those topics that are harder to ask about in a survey. Okay, well now I'll hand it back to JP, so next slide, please.
Thank you, Drew. Before we conclude, I'd like to update you on where we stand with our timeline for this project. The bottom line is we remain on track for substantial completion in January, with the final presentation to this board in February 2027. Our staging process was delayed by 1 month due to delays in our contracting approval. However, we've been able to make up for that time by reprioritizing staff and other work. Our most significant change has been to accelerate the schedule of our Phase 3 capabilities and gap assessment. We've moved this work up and prioritized it in order to be able to utilize this information to inform other planning initiatives that are underway, which includes our downtown campus comprehensive plan and our overall comprehensive facilities plan. And with that, we'd be happy to answer any questions you might have.
Okay. All right, we started that way last time, and we're going to start in the middle this time. And watch me not keep up with it. But that being said, let me start with Maram, and then we'll go this way, and then I'll come back to you guys.
Well, thank you for the presentation. Really appreciated it. A few questions. In terms, I've just noticed the surveys. I see the population. Have you done any targeted focus to folks who are from other ethnic backgrounds, like Middle Eastern? I'm just thinking about, especially given the languages that
Absolutely.
you have.
And we're actually translating the surveys into 5 additional languages, or excuse me, 3 additional languages to match the top 5 languages spoken by our patients.
Okay, perfect. So another thing, I think you all are doing a great job, and I'm glad to see that as you're conducting these surveys and interviews, you're doing preliminary findings, and that helps you as you're moving forward. We are in the midst of our budget and proposals, so I think it might be helpful, if possible, to offer us, even if it's not complete, and I understand it's still preliminary data that you have, perhaps communicating some of your key findings, if you have any, to Anissa, as it could help us to refine our priorities with our board initiatives moving forward. I understand your timeline may not coincide with our proposals, but given where we're at, that information might be helpful, that we're whatever we're proposing is a need, and it's data-driven from our community. So that would be helpful if possible, but I do understand where you're at with your data collection and analysis. Again, thank you for your efforts. I really appreciate this and look forward to the final report. Thanks.
I'm going to go now to Geronimo, our chair.
No, thank you very much for the update. I appreciate the timeline and where we're headed. Thank you.
Thank you very much. This is an issue that's near and dear to my heart. I'd like for you to add, if you haven't already, but making sure that you're touching base with the advocacy organizations that deal with our poverty population, marginalized communities, other than English-speaking populations, and making sure that they are included in your surveys. Their information is included in your surveys and in the development of the focus group membership as you do that.
Absolutely. A lot of conversation and thought between both the organizations was given in the development of the key informant lists, which are truly representative both of governmental entities and other nonprofits, and then really leveraging those relationships so that when we have the focus groups, we have those nonprofit partners, those folks who deal specifically with our patient population. So of a variety of different ethnic and language backgrounds. So that is top of mind for us.
I appreciate that. Thank you very much.
Dr. Brinson,
No questions, thank you.
Dr. Martin.
I got a question on the focus groups. I don't know anything about this sort of stuff. Is that a standard size sampling number?
Yes, we're following best practices, both from our internal expertise as well as the consultants.
Okay, thanks.
I think we still have Manager Jefferson and Manager Kitchen, but I'll start with Manager Jefferson. Do you have any questions or comments?
Glad to hear that you're going to reach out to key organizations that work with the targeted population. I hope Legal Services is one of those. That's it.
And Manager Kitchen, you're no longer online? Okay, very good. I'll reserve the last comments. First of all, thank you for the work that you're doing. I will take full responsibility for the fact that you started out late, but I always had confidence that you were going to make up for the time because I know it can be done. So thank you for doing that. And as it is, you're still going to finish up in February, which is what the time that I kept telling Monica, where's Monica, that we could probably finish in February and that we would be fine. So thank you for all of that. And we look forward to continued work with each of you. Thank you.
Thank you so much. We appreciate the time.
Thank you.
All right, the final item that we've got on this agenda for SPC. No, this is it. This is it. We've got Focus Safety Net. That was the one we just did. The strategic plan. That's one more. That's it. Yeah, that's it. Okay, the last one is for us to discuss receive and discuss an update on the proposed Central Health Strategic Plan. And then we've got Anisha Kandal presenting, as well as JP also? Okay.
Thank you, Vice Chair. We will keep this verbal update brief to stay on time. Since our last update to the board, the staff has engaged with the governance consultant Karma Bass for a proposal to work on the strategic plan. This would build on the foundation she has already established with the board and continue the work focused on the mission, vision, and values. We have requested a proposal outlining how her team could support the next phase of this work, including strategic planning facilitation and development of key deliverables. A benefit of leveraging the same consultant is continuity between the governance and strategic planning efforts, and it helps to ensure that the work remains aligned with the mission, vision, values, and reflects the board's priorities. And we expect to have additional information and potential next steps to share with the board next month. Thank you.
Thank you. Any questions? None? All right. Thank you very much. Appreciate y'all being here. Okay, managers, one last little announcement before we move forward. This is something new that we're going to try to institutionalize when we finish our meetings. So I'm going to pose to you as chair. I want to get your feedback. If all of you believe that this SPC meeting met your objectives, your questions were answered sufficiently, and if this meeting was a good use of your time. And we also want to know if we could do any improvements on the meeting as we move forward. Further, while our next Central Health Strategic Planning meeting is tentatively scheduled for Wednesday, July the 8th, I know that in the next session, we're going to have some discussion about perhaps taking a look at the month of July and see how that might impact schedules, visiting and vacation schedules. So I'll let the chairman at that appropriate time talk about it. But with that, we'll go ahead and continue to move forward with the work that was presented today. And I thank you very much for your feedback. Your feedback can be given to me very quickly right now, if you can make it on a one line, or if you like, you can email me or text me. It doesn't matter to me. So if you want to say anything today about that, just make it real quick. And if anybody does, who do I start with? Maram.
Can we have an anonymous survey?
You weren't even here for half the meeting.
Well, I just want to commend you on a great meeting and for taking our questions. So, well done, Chair. Again, thank you. We appreciate your efforts. So that's really my comment for you.
Thank you, my dear. Appreciate that. On this side of the room, do we have any comments, Dr. Brinson?
Well, I was sitting here thinking what a wonderful job you did. And so I really am grateful. I mean, it's just really a whole different place. But I would add that the point of order for me, this is moving along, wonderfully. But I still think, you don't need one of us to interrupt. You could probably just do that when you feel that it's a good point of order.
Okay,
Yeah,
thank you very
thank
much.
you,
Well
thank you.
taken. Dr. Martin?
As I've told Geronimo, I think that meetings to become markedly efficient and with questions answered, and in a direction for what the point of the meeting is.
Yes. Well, thank you. And Mr. Chairman?
I think we're getting better at effectiveness and utilization of time, and we'll continue to improve around this. But I think a lot of this is, there's a lot of priorities, there's a lot of things going on, and it's really important for us to get the high level updates and for us to ask questions along with our comments as well. So appreciate it.
And then Manager Valadez?
It was great. Thank you, Elisa. I do want to ask Jeronimo, because I think you would be able to tell me better. If we have issues or deep concerns about the ages of populations that we see that there is a gap whose needs are not being addressed, should we put that as an agenda item here, or maybe go to community care since they're dealing more with primary care as opposed to central health?
Thank you for the question. I think while we're trying to improve or just get better around our governance, I think probably the question that at least it was also in her comments was asking, like, if there are issues or concerns that you all have, please share them with the appropriate chair of the committee or to the officers of the board. And it's going to be our responsibility to get back to you and address that with administration, with Dr. Lee, probably in our one-on-one meetings with him, and then we'll try to address that. I mean, I think your comment was very well taken about the need for the gaps in services for children around mental health continuum and the elderly. And I think those are issues that are obviously important, but we've also got to make sure we're measuring against what's on the agenda, what's the priorities, and we'll manage that with Dr. Lee around the issues. And as you bring them up, I hope that you'll see them in the board tracker to make sure that it's not lost and we haven't forgotten about it, but there is trying to be some level of balance to kind of our time here and respecting our private lives as well.
I appreciate that. The reason I brought it up is because I believe that there was supposed to be some meetings begun between Central Health and other agencies, governmental agencies and advocacy organizations. And if there is, in fact, if those meetings are occurring, I'd like to be invited.
We'll take it.
Thank you.
All right, how about Manager Sedora Jefferson, might you have any comments for us?
I thought it was a very efficiently run meeting, and I really appreciate the way you went around and gave space for everyone to make their remarks. And I think that's very important because, we've each been appointed to this board to have voice. So thank you.
Thank you very much. And on the last note, before I take a motion for adjournment, I want to thank staff. Staff, you all are the backbone of all this work. So we couldn't be doing this without you. So thank you very much. And by all means, keep it up because we've got a lot ahead of us, as you all know. Thank you very much. Okay, at this time, I am ready to accept a motion for adjournment. It's been moved by Cynthia Valadez, and second by Dr. Brinson. All those in favor, please signify by saying aye. Aye. Fantastic. Meeting adjourned at 5:49, and that gets you in time for your meeting before 6. Yeah. That's great. We're working on it. That's good.
So Manager,
That's good, yeah.
food is in the other room, so if you can get your food, and then we'll try to get back here by 6 o'clock, since we also, if you would take a restroom break in between two. be out. We'll be out, I think, by 7:30. Yeah. Good afternoon. Today is June 10th, 2026, and it's 6:10 p.m. As a quorum of the committee is in attendance, I'd like to call to order the meeting of the Central Health Executive Committee. And as a reminder, some of our committee members may also be participating by video conference, so the staff will be managing video and audio feeds of all participants closely to make sure we have a legally compliant meeting at all times. I'd like to also announce that in order to make it more accessible to community members, we previously held public communications for the Strategic Planning Committee and Executive Committee meetings at 3:30 p.m. unless a member of the public wishes to comment on a specific item on this agenda now. And I don't believe we have anyone. So members, we're gonna move to the committee agenda. Item number 1 is to approve the minutes of the Central Health Executive Committee on May 13, 2026. Do I have a motion?
So moved.
A second? Okay. Yes. So having a motion by Manager May and a second by, it has to be a committee, by Manager Mercedes. All those in favor, please raise your hands. And the motion passes unanimously. So I'm going to move to item number 2, which is to receive and discuss a report from the board chair, including board meeting mechanics and governance updates, tentative schedules, and our Texas Healthcare Trustees Governance Conference. There's a couple of really quick items. One, just to keep you updated, the Vice Chair and I and Dr. Lee will be having an update meeting along with Bedla as well with Karma, our governance consultant, to kind of check in with her about how things are going and potential next steps about any additional meetings that we will be having for the rest of the year. So I wanted to give you an update on that. 2, in the attachment, the board tracker is on there for your review and update. So feel free to email or call one of us if there's something there that's missing as we continue to work with the staff on those issues. And then in terms of tentative schedules, I know I'm going to be out of town June 28th through July 15th. And I think we're going to try to cancel some of our meetings that we have in July. And so I just wanted to make sure, and I think there was some handouts, right, Bella, that came out, or some kind of asking for your feedback about time that you're going to be out of town, vacations with your family or other issues. Because we wanted to just put it out there that potentially, I think in July is going to be a slow month, and just to give a break to our staff in terms of focusing on their work and their vacations as well. But I wanted to just let you all know that I think we've been going at such a hard pace that we're now just slowing down right before we need to prepare for our budget season. And then any other issues that might come up by the end of the year that I think we've had discussions in executive session before. So I just wanted to make sure and comment on that. Manager Mercedes?
Well, I will be out in big chunk of July, so can I propose a motion, like, to cancel July's meetings? I know can we take a break? So I know, like, there's other, and I think Dr. Brinson says she's gonna be out sometime in July. July, you said also? July, right? But again,
I appreciate it. I don't know that we need a motion. I think when we talk to Dr. Lee in the one-on-one, because that's when we do the scheduling, but it is great input to give, because unless, I should put it another way, unless members object, I think we're gonna try to minimize the number of meetings in July up to and including 0 meetings.
So, Chair, in the
Yes.
past, there was I don't know when, but that July was off for us, right, Dr. Brinson? So yes.
Yeah.
So
So
it was canceled, the meetings in July.
So let me clarify, at our next one-on-one with Dr. Lee, we will be asking whether there's anything that's legally required that we need to meet for in July. or there are things that we can move to the next month that can be ratified instead of approved. But we'll work on that, because I do think that there is a time to rest and a time to focus on our work. And so hopefully July can be that month for us. And then the third, unless there's any other questions, and then the third item is that we know it was a little bit of a short notice, but we invited our board colleagues, you all, to attend the Texas Healthcare Trustees Governance Conference in San Antonio. And 4 of us were able to go. So we thought, in the spirit of both transparency, accountability, responsibility, that I might invite those 4 board members to share a few takeaways. And so, Manager Jefferson, just so you know, I also picked up some extra copies of the 2027 Governance Committee, the next Texas Hospital Association Annual Conference brochure, and the brochure on becoming a certified healthcare trustee and leader, so that you all can take a look at all of those. And I would invite some of my colleagues who were there, who were ready to kind of share some takeaway. I don't know if Manager Jefferson, I don't know if you want to start, kind of just share a few takeaways.
Sure. I was there Wednesday through Friday, actually Thursday through Friday. Thursday was the early conference for new hospital board trustees, and the conference was focused on hospital board trustees, which I thought was fantastic. I'm so glad that there's a group that we can go to and to network, to learn from. And so anyway, I was there Thursday and Friday. I didn't stay through Saturday. So I think a lot of the materials on fiduciary duties and so forth weren't new to me, but was very enlightening and new for me was they were talking about some of the responsibilities of a hospital board in relation to quality, and how there are certain required reports. And, at one point I thought, well, this might only apply to private hospitals, but it applies to public hospital districts as well. And that was very eye-opening for me, so much so that, I just, and I mentioned this to our chair, I really feel that our board might benefit from someone to kind of help us understand some of the required and some of the advisable things that we should be seeing. And maybe Karma Bass is the one, and if so, that's fine. But I would like us to get that kind of insight and guidance from her, because those were their required reports that are necessary. Also, in the compliance area, I went to a couple of sessions on compliance, and a lot of it had to do with, what hospitals do. But more importantly, there was some content that was provided by one of our outside legal counsel, by the way, that talked about how if the CMS, the regulators, whoever they are, CMS or whoever, comes in, that they always frame the deficiencies in terms of the board failed to do this or that. And it started with the board, even though to me, a lot of the issues were more operational. And so that reinforces my desire to make sure that we are getting and the required and the advisable kind of reporting on a cadence level that's considered good governance from our consultant, Karma Bass. And I'll just leave it at that.
Thank you. Manager Mercedes?
Oh, well, thank you. I actually attended one day on Friday. It was very insightful, and I wish we knew about this long time ago. And I think what was helpful is understanding our role and our governance structure along with others who are in the same shoes. So it was primarily about knowledge sharing, and also it could have been a resource, because some of the issues that we have encountered or we planned or whatever comes across, we could have asked, another board, how did you approach this situation? What's your advice? So building, learning best practices from folks who are actually doing similar work. Their structure might be different, but they ultimately do similar work. What I've primarily focused on learning is an AI and governance, and to me it was quite an eye-opener of things that falls on us as board members in terms of a policy that we need to institute. One thing that we could learn from, and we should, from Harris Health, how their policy, how they're adapting their AI policies. They're actually, so one thing they clearly said, when you don't know, it becomes very risky. And we need to clearly understand where we stand in terms of our policy before we even implement these AI tools in our clinical setting. So that's the thing, you need to establish the foundation, then proceed with the clinical settings, as we've heard today from our providers. There's potential to bring in that aspect, but if as an organization we don't know how we're working with it, so it becomes very tricky. So, and also one thing they mentioned, even within their procurement, the language it has. So they also wanted, they look very clear. So their process is very thorough. But one thing that came is that no one person should own the AI within the organization. It's not just the clinicians, it's not just the IT. It has to be multiple folks, including some perspectives from the board and then in terms of governance, but also what we also heard today, including physicians, because if they're not part of the conversation at the beginning, it's hard for them to accept and implement rather than you're imposing. So what I'm hoping that we, in the next coming months, because it is very evident, this is the direction of the world, that we need to set a policy and also what is acceptable even within our staff, what to use, what is acceptable. So again, we don't know what Central Health is doing, and that should, and I see our compliance officer here, so we need a policy around it to understand and build these measures, and also seek out what others, like Harris Health, and I've also got a contact person, and there's also training for board members around that key item. So that's from my perspective. So I think, and I see also the chair, I think, attended a session prior, but this is something that we have not really discussed. We've been busy with other issues that we need to pay attention, especially if an auditor came in to ask what is our policy around AI use for our employees, our patients, and we need to, as from a governance perspective, lastly, we need to know everything that touches the patient. So that, keeping that in mind, what touches the patient is our responsibility. Thank you.
Thank you, Manager Mercedes. Manager May?
So I went to all of the different breakout sessions that had to do with governance. And boy, it was an eye-opener. I would highly recommend this conference to all of us to participate next year. This conference is focused on the trustee relationship and the trustees' role. So that's what's good about it. It's not about how do you run the hospital as administrators. They have that as well, but this was for us. So I know that this came at a short period of time, but next year, please be thinking about it. It's going to happen in June, and I believe it's going to be in Plano, if I'm not mistaken.
Frisco.
Where's it? Oh, that's the one for the administrators.
Oh, okay.
But the one, did you say it was Frisco?
Yeah.
Yes,
Yeah,
Frisco.
it's gonna be in Frisco in next June, so I'm gonna really recommend that to all of us. But that being said, here were my takeaways, and I was just kind of really, I don't even know where to begin. There's so many good things, so many golden nuggets. I guess what I would start with is this, that healthcare is evolving faster than the governance that we have in our own table here, if you will. And there is a healthcare governance gap between the board, how quickly the board can implement new policies and how quickly it can catch up with the realities that staff is dealing with at the patient level. So that was something that was really good. They talked about the pace of change was very fast, governance gap, and that we had to have very broad preparedness. They talked a lot about integrated governance, which I thought was a very interesting model, because basically what they're talking about is the very sophisticated boards, and we're not there yet, because first of all, we don't have are we an open or close?
Open.
Okay. We don't yet have a completely fully realized system. I think y'all get my drift, okay? But because of that, it's when we do when if that effort ever comes to be, those that are living in or working and operating in a fully integrated system, complete system, there is a shared governance model that they're beginning to operate under, where you're having to share, this board shares with staff and the staff shares with us some of that governance that's expected in order for us to be able to lead and survive the changes that are coming up. Because I'll go back to it, the changes are so dramatically happening so fast, and because of the AI is I mean, it can either be our friend or it can be your enemy. In our case, we have to be real careful that it doesn't become the enemy, because we're going to have to be able to integrate with it very quickly. So that was one big takeaway. So let me just say that the traits of high functioning boards, I'll give you 7 core elements that I thought were really good. And I may not have them totally all in the order because I was writing as fast as I could. So the 7 core elements include recruitment, the recruitment of your board membership, the structure, the cultural development, competencies as it pertains to leadership, succession planning, having a board portal, which we're working on, consent agendas, using them a lot so that you can move your meetings a lot swifter, and that you can move more of the heavier topics into your full agenda, and then just move on with the other topics that you've already covered. Like, for example, I'm going to use it because this has been my heartache. Let's take, for example, the foundation board. How many meetings have I had? I've been working on this thing since May of last year, So, I mean, it's been over 12 months, right? And I'm just now getting it over the hump, if you will, and hopefully putting it on the agenda. But I'm not even sure that I can get it even over the agenda on the next round, because there's always something that we've got to still clean out. We have to get past things like that, okay? Basically, was my takeaway. They use the executive sessions to the fullest and to maximize their efforts in terms of work. They have term limits. That's something that I'm not sure we have, but we need to take a look at term limits. They make sure that they have an equal number of women on the board and an equal number of minority members on the board. And then they adopt diversity. They adopt diversity. This was very good, because we need this in terms of board representation. What does your board need? Not necessarily by color, not necessarily that you're male or female. It's what do you bring? What is your expertise, and what are you bringing to the table? So, like, if you're a medical doctor and we're needing your expertise, that would be a piece of what we're talking about. Yes.
I don't mean to interrupt you, Lisa. I think that's great. I think it's really true. Oh, I'm sorry. I think because, the county commissioners and council, they need direction from us, from you guys, especially as chair and vice chair, Sue. What are the needs of the board?
Yes.
We need finances, we need a lawyer, we need a doctor, whatever the case may be. But I think that's so important that really be, and then the board also, I speak of Cynthia as well, that, we kind of came on virginal, not really knowing, like, what are we doing, right?
Yeah.
And I think that there should be a course, the preparation to train, get ready for the board, take the courses you need to take, get ready, and then plan on then doing something. Because I think I know personally the uptake has been slow, and I think it'd be very beneficial. But I think we have to have a communication, a blunt communication with those people that appoint board members.
Especially now that we're evolving.
Yeah,
we're
we
gonna
need some expertise.
The expertise that we need at the table is gonna change. So with that, I'll just say my last closing comment, because I could go on and on, because I love this conference. But I'll just say that one of the things that I walked out with, intentional governance builds capacity. So if we are intentionally working on our governance, it's gonna build the capacity of the whole. And that obviously will benefit the system and no, I mean, I can't help but think that it doesn't then benefit staff because they'll know where we're going and how we're operating. So I'll stop there because I really could keep going on, but thank you for allowing me to share that.
Thank you. I've got just a couple other thoughts. I think one of the biggest values, I think, was just being able to talk to our fellow board members in a setting that's not just about the agendas that we're doing. So I really appreciated spending time with all of our colleagues. The other thing I might mention, I'd be remiss if I didn't mention, is that they have a Texas Healthcare Trustees Governance Achievement Award that they give every year. And this year, they give it to the Uvalde County Hospital Board, which, as you know, not only had a shooting, but also COVID-19. They had so many different issues. But what was really interesting to me was that, and I'll read from what they said, is that what distinguishes this board is that transformational growth has never come at the expense of culture or connection. And I thought that was really important and just was really appreciated them highlighting this particular county healthcare district. I will say that there's a couple other thoughts. I think one of the sessions really kind of gave me a little bit of insight into the future, because they said the future may belong to organizations willing to question assumptions before circumstances force them to, and that the most important governance questions are changing, not only around performance in the present, but also asking questions that involve assumptions about the future. And I'll just share with you some of them, like, what must remain deeply human? What does our community need most? What role should Central Health play? What must remain local? What can scale digitally? What partnerships matter most? What capabilities will differentiate us? What should we stop assuming? So I thought that was really interesting. When it comes to AI, Maram already mentioned a lot of it. I think in discussions with Dr. Lee, I know they're working on bringing us something, which I really appreciated. They're already thinking about that and kind of going through it, and I won't, I think Dr. Lee can explain that. I think one of the things about AI that blew me away was the experts saying that artificial intelligence doubles in its capacity now every 4 months.
Yeah.
And even more interesting is that doubling of capacity, that AI is coding itself for its next version. Which again, it's like
Scary.
well, and there are some pilots out there that are working on replacing doctors around medications and stuff. So that's way out there. I think it's in Utah as a pilot. But AI is with us. It's been with us for a long time. If you have an iPhone, you have AI already. But there's a lot of fear and concern, which goes back to Maram and the policy and kind of what those issues are there. And I'll just mention one other thing, because I took a lot of pictures of their slides. Adaptation is really important. There was a quote by the head of Microsoft that I thought was really good, is I don't need a team of know-it-alls, I need a team of learn-it-alls. And a learning organization and a growing organization is what's gonna help us adapt to the future in healthcare. And then the last one is literally the last slide of the entire conference was that the future is shaped by the choices organizations make before change becomes unavoidable. And governance can help with that. And so I would encourage you all to look at the certification pieces. I would encourage you to go to the next conference. There was a lot of really good colleagues from across the entire state of Texas that are hospital districts, that are healthcare districts, governmental entities. And so I thought it was a good use of our time of being there. And Manager Mercedes.
Yeah, and one thing that also I noticed, and something that we as a board have had some challenges and around. One thing they said is success of an organization is built on the relationship you have with your CEO. And that is the way how we can, and especially the relationship with the chair and the CEO, it is really the driver, the force of success for the organization. And one thing within this the organization, the Texas Healthcare Trustees, what they offer, and something that we should perhaps consider, and especially we're discussing this in executive session, executive committee, is that they have a source, a tool for a CEO evaluation. That maybe we could consider as a third party that is evidence-based, that also addresses some of the concerns of board relationships and trust. So I can share that.
With all of
She's
us,
smiling over there.
So yeah, so they can evaluate, and it's really, the cost is minimal, and it's a non-biased evaluation, and they help you build these successes on really metrics that are quality metrics, are evidence-based, rather than us trying to pull in what objectives we want.
reinvent the wheel.
So
Don't reinvent the
that's
wheel.
something perhaps we should consider moving forward. So that's
Yeah.
what, sorry.
No, thank you.
I'm glad you brought that up.
I'm glad you brought that up because as you were talking, I was handing Dr. Lee the brochure around the optimization of organizations and the CEO evaluation. There's also, members, a parallel online board self-assessment that will probably just inquire about both of them. So that way we can see if this is a tool that we can use, and other healthcare districts, hospital districts are using it across the state of Texas. City.
Is it possible to acquire Geronimo or Dr. Lee? I'm sure somebody was filming this. I'm sure they were taping the conference.
Yes, we have slides for all the presentations that are available to us via email. I got the email.
link.
Yeah, we
No,
have.
if you can share that with the board, I'd appreciate it.
Sure.
Yeah,
Yeah.
because the slides are real good. I mean,
Yeah.
they're,
Oh, yeah,
they're very good
they'll
content.
be self-explanatory.
Yes, and for the lawyers that are part of the board, there is CLE credit for part of it, and two, for those of you that are members of the American College of Healthcare Executives, there's over like 13 or 15 hours of time. I might be mentioning that because I'm a member of both of those, so I'm going to get credit for both. but they have really good educational opportunities and some really good speakers there, so really encourage it.
One thing that, Geronimo, you mentioned Uvalde, and one thing that really stood out to me is that the relationship the board members have amongst each other. And I think what they've said, that they've had a stable board for a long, extended period of time. So I think we're heading.
We're headed in that direction.
So, oh my God, you guys. The bottom line is, if we want the success of this organization, we need to work on our relationship. So that's really the key message that I want to relate to all of us.
They picked that county or that community because if you know Uvalde.
Yeah, look at everything that's happened.
It's regional.
No, but it's
Yep.
very, in comparison in size, in comparison to us. They grow up all being related to each other.
Yeah,
They all have relationships with each other.
They have a brand new hospital as well there. I will say that one of the board members had served on their board for over 50
years.
50 years.
I was just gonna
50.
say that.
Still alive?
Yeah.
Yeah, she was there. She was there.
And he was there.
Yeah. Is it he or she?
It was a he. It was a he. Yeah.
What was he? White or?
Sure.
Right.
I don't remember. I do not recall.
No, I'm gonna tell you what.
On the advice of my attorney, I cannot recall.
Racist attitude and the segregation attitude that Uvalde's had to go through.
So those are some of the key takeaways from the conference. As you can tell, we're still kind of processing that. We'll forward that email with that has the link to the presentations. Members, if there's not any questions or anything, I'm going to move to the next item, which is item 3. Receive and discuss a resolution approving an amendment to the bylaws of the Sendero Health Plans regarding ex officio members of the Sendero Board of Directors. And there's no motion here, and this item only was supposed to be like 5 minutes, maybe less if you have questions. But basically, Sendero Health Plan Board has submitted a resolution with one word change about the service of the, can you? Turn, yeah,
Sorry.
that's okay. I was hearing double.
has asked for a change. There's a one-word change from shall to may for the board chair to serve on the Sendero Health Plan. And there's two reasons why they've done that. One is I was not able to have the capacity to do both all of the meetings at Central Health and then also Sendero. So I asked or chose not to attend those meetings. One of the things I learned from Sendero is obviously they're a highly regulated entity in the insurance field, and they're required to submit paperwork to the Texas Department of Insurance. And so what this does, it relieves them from doing that part. And so we thought this was the quickest and easiest thing to make sure that we are in compliance with regulations from the Texas Department of Insurance. And potentially in the future, as I had told Sharon and I think Dr. Lee, that I hope that at some point it might parallel something like we're doing with the foundation, where the chair or their designee or another board member can be appointed. But I think for now, the easiest is to just switch from shall to may, and then we move from there. But that's really what this item was for, and that's why I wanted to have an opportunity to explain it to y'all before. It's expected to be on the Board of Managers voting meeting on June 24th. So I didn't want to surprise you all with that on that particular day, but I'm happy to answer any questions. I know Manager Motwani's not here, but I know that he has some questions for me, and this was the explanation of like why wouldn't you go to those meetings? But I'll visit with them separately and answer any questions. But members, I don't know if you have any questions, but if not, we just wanted to make sure and let you know about that. Yes, Manager Jefferson.
Thank you for clarifying that. Quite frankly, I couldn't tell whether the existing language was permissive to be made mandatory, but apparently it's the other way around.
It's the other way around. Yeah.
So when it comes to the board, if that could be, for me, it's going to be an easy yes, but if it could be made really clear, that would be helpful.
Yeah, definitely. Yeah. Thank you. I think we're gonna, with no other questions, I'm gonna move us to items 4, 5, and 6. So I announced that the committee is convening in closed session to discuss agenda item 4 under Texas Government Code 551.072, deliberation regarding real property, and or Texas Government Code 551.071, consultation with attorney. Agenda item 5 under Texas Government Code 551.071, consultation with attorney. And agenda item 6 under Texas Government Code 551.071, consultation with attorney, and Texas Government Code 551.074. And for our public agenda item 4 is to discuss Central Health owned or occupied real property and potential property for acquisition, lease, or development in Travis County, including next steps in the redevelopment of the Central Health downtown campus, administrative offices of Central Health Enterprise Partners, and new developments in eastern Travis County. Item 5 is to receive a briefing and take appropriate action on issues related to Travis County Healthcare District doing business as Central Health versus Ascension, Texas, frequently known as Seton Healthcare Family, cause number D1GN 230000398. And item 6, deliberation and possible action on the appointment, employment, evaluation, reassignment, duties, discipline, or dismissal of one or more Central Health employees. And with that, members, the time is now 6:43, and we'll be going into close. ready? Okay. It is, good evening. It is June 10th, 2026 at 8:28 p.m. And we are entering our open session. And members, I think the only thing we're doing is sharing that our next executive committee meeting is tentatively scheduled for Wednesday, July 8th, although that may change, at 3:30 p.m. at the Central Health Headquarters, 1111 East Cesar Chavez, Austin, Texas, 78702. And members, at this time, I'm ready to accept the motion for adjournment.
I move.
So Manager Musaitif moves and Manager Valadez seconds.
Me, because it's the executive.
Oh, I'm sorry.
Oh, she can?
She can make it. Oh, got it. Okay, so Manager Musaitif makes the motion, Manager Valadez seconds. All those in favor? Elisa? So the motion passes unanimously and we are adjourned at 9 p.m. Good night.